go ahead and get started. It's 5 after 12 and we have a lot to cover again. Welcome to Series 3 in our SI Partnership Program. I'm Robin Seeger and I work at the Broomfield site.
And I'm Karen Williams. I'm at the main campus.
And this session we're going to focus on the tactile system. If you have printed out your PowerPoint in notes version, you'll see all of the notes from us, or the majority of them. So feel free to just listen and understand that this is an introduction. We don't expect you to have a full command of this information as soon as we're done with the lecture, and we have follow-up activities designed to help you continue in your learning in this area. The sensory systems most closely aligned with original Ayres SI theory are the tactile, vestibular, proprioceptive, auditory, and visual. And our next several lectures in the series are going to focus on a separate system. The focus of today's presentation will be the tactile system, and more specifically tactile perception, or actually discrimination and perception. Ayres did address tactile reactivity or defensiveness and began to discuss the concept of sensory modulation problems, but we won't be addressing that today. Remember, there will be another lecture specifically on modulation issues, and that's scheduled for cycle 7. Remember again that the focus of this series is on kind of getting ourselves back to remembering what Ayres' original theories told us and how that has driven evaluation and treatment. So when you talk about the tactile system, you'll often see it referred to more as the somatosensory system. And somatosensory is talking about tactile and proprioceptive information combined. And that's really kind of more accurate terminology because these systems are very intimately connected. But each system does serve a separate purpose, and so we're going to spend some time considering each system separately. You'll see here on this slide that there are 3 different pathways or tracts, systems, whatever term you want to use, over which tactile information is processed. The DCML, which stands for dorsal column medial limniscal system, is primarily a discriminative system, and its receptors respond to mechanical stimuli, which just means that when a mechanical stimulus is applied, there's transduction occurs, so the impulse begins to be processed through the system. Mechanical stimuli include tactile, vibratory, touch pressure, and proprioception, but we are not going to be talking about proprioception today. DCML, or discriminative systems, are associated with the detection of size, form, contour, texture, movement across the skin, which is really critical, and localization of pain, not the response to pain necessarily, but the information about where the painful stimulus is coming from. Anterolateral system tends to respond more to rough stimuli, and it mediates pain, touch, temperature, and it does also participate in localization of pain. And AL pathways project to regions of the brain responsible for arousal, so in particular the reticular system, and there's direct connections with the limbic system to provide emotional tone and the autonomic regulation system. And then trigeminothalamic is the system that processes tactile information, tactile and proprioceptive information from the head and face. Both the DCML and the AL systems carry both discriminative and valuation information, but they each have their more primary function. Ayres discussed and focused on the tactile system a great deal in her original work, and she described impairment in tactile discrimination as an apparent problem with processing the spatial and temporal aspects of information gained through touch. She talked about how important touch discrimination is to the development of the tactile perception necessary for a development of body schema or body perception. And then she related tactile processing problems to dyspraxia and its effect on occupational performance or daily function. A brief terminology side note here. Ayres talked about tactile discrimination a lot, and her set of tests to look at tactile function were called tactile discrimination tests. The new ASI group is using more the term perception. The way I learned about this is discrimination is more about the neural input and specific discrimination of touch, and perception is kind of that process whereby information is put together for a sense of something or a map of something. So why do we care about what's going on with the tactile system? Well, it's a critically important sensory system to our overall development, and you'll see several bullet points listed here about what the tactile system provides us. It's a significant contributor to behavior, and remember, behavior is just stuff that we can observe. Touch is our first language, so when you're first born, that's the only thing you have available other than vision a little bit to interact with your environment. It's the first system that is functioning or online in utero. It is critical to a variety of things for survival, like nourishment and calming and attachment. We are very dependent on touch for all of our functions, and in particular, what we need to be able to do is interact with our caretakers until language, motor skills, and cognitive processes emerge. So touch is critically important to social, emotional, physiological, and neurological development. So think about that. If we have an impaired touch system, it's going to impact how our brain develops as well. Let's see. This understanding of how touch contributes to attachment is part of what has driven changes in neonatal care, and I think it's called kangaroo hold, or I'm not sure exactly the terminology used, but the idea behind that is body-to-body touch is so important for attachment. So it's just important information to know. Some other things that were interesting when I was reading about this is that there have been studies that showed that touch input through the discriminative system drives exploratory motor behavior, the purpose of which is to gather more touch sensation. So in that vein, it drives your motor development as well. And it makes you think about touch seeking as not necessarily a modulatory or regulatory kind of activity. It could very much be drive to get more detailed information about your environment. The other things that are listed here we can talk about a little bit more later. The final bullet, DCML is important for selective attention, orientation, and anticipation. We think about those kinds of things as being very much cognitive functions, top-down, whatever terminology you want to use. But as we mentioned in the last lecture, for those systems to function effectively, they have to receive well-organized sensory input. So we'll digress a little bit more into the neuro, and you guys have learned all this stuff before. Don't let it overwhelm you. We tried to streamline to information we thought was going to be important to understanding how treatment activities and assessment activities have been developed. So in the touch system, every sensory system has receptors and a process of transduction, which just is translating the sensory input into a neural impulse. In the touch system, the receptors are all mechanoreceptors, which we talked about briefly already, including light touch, deep pressure, stretch, and vibration. There are two different types of mechanoreceptors. One is called fast adapting, and they respond to the start and stop of input. So they don't give us a lot of background information about what's going on. That's the responsibility of slow adapting mechanoreceptors. Those are the ones that continue to respond to sustained input. This is true in both tactile and proprioceptive systems, but I think tactile has more fast adapting receptors and prop has more slow adapting, which makes sense because prop really needs to give you background information about your body. Thermoreceptors are also considered to be in the touch system. Ayers didn't really talk a lot about this, but I just thought it was interesting that it's in the touch system because it is something that we see a lot. You hear all the time about how kids need to be in freezing temperatures before they're ready to put on long pants or wear a coat. And so, I'm not sure exactly what's going wrong there, but thermoreceptors are primarily associated with the hypothalamus, and they have primarily a regulatory and homeostatic responsibility or function. More about receptors and transduction. And these things, I think, really give us information about why we choose the kinds of treatment activities we choose. So the use of active touch allows for finer and more accurate discrimination. So think about stereognosis. You need to be able to move an object, unless it's a really simple, well-understood object, to get the detailed touch information you need to identify it by touch. There are actually areas of the cortex that respond only to that moving type of touch. Oh, I'm on the wrong page. Am I? I am on the wrong page. Sorry, guys. Do you have this one? Okay, sorry about that. So go back to the other one. I don't know what's wrong with my thing here.
I think you stapled it.
I stapled it backwards? Okay. Sorry. Tactile discrimination and perception depends, this is better, depends in part on receptor density and associated size of receptor field. So the receptor field is just the area around a receptor that responds to input, and receptor fields do overlap. Receptor density just refers to, how many receptor cells per area, per square inch. So for fine discrimination and skilled perceptual and motor functions, you need high receptor density and small fields. So think about, we all learned about how to test for 2-point discrimination when we went to school, and there's a much higher 2-point discrimination or smaller detail of 2-point discrimination in the hand than there is in the arm or the rest of the body. That's what, so that you have smaller fields with more detail in your hands and other parts of your body. Your mouth is another area where you need that kind of information for skilled motor function. Where there's less specificity needed, you have low receptor density, so fewer receptors and a larger field. Let's see. So one of the examples of how to think about this that was offered in the book is that think about the difference between a touchpad on a phone versus a keyboard. That's one way to think about fine discrimination or small fields versus large fields. The other example that's used is if you're sitting in a big lecture hall and you have a lecturer who mumbles or is talking really quietly, the receptor field is going to be limited to those people right in front of the lecturer because the stimulus is not big enough to get other parts, get to other people in the larger areas of the lecture hall. One of the other things that helps me think about this detailed stuff is if you think about the homunculus, which is one of the areas that this sensory information is processed, think about how big the representation is of those areas where there's high density, high specificity, fine discrimination. Okay. No, let me just see. So now we're going to this one that I started talking about already. If you look lower, if you look in the notes on this page, we're just talking here about the different types of processing that help to refine tactile discrimination. So one is the use of active touch, and then the other is this importance of lateral inhibition. So there's actually synapse, or a process that occurs at the first synapse in the nervous system with tactile discrim system that sends a message back to the receptor field that's receiving the information that says, you cells on the outside of this field, stop talking so much. We just want to hear from that cell that's in the middle. And that gives us detailed information. This is a type of sensory integration or sensory processing that can affect discrimination. Let's see. So that's all detailed here in your notes. Again, one of the ways to think about this is in that lecture hall idea, not having good lateral inhibition leads to a really general kind of input. So if it's in the touch system, you get a general idea that you were touched somewhere if you don't have lateral inhibition. If you're talking about the lecture hall idea, not having lateral inhibition is like having a mumbling, quiet lecturer in the front of the hall and lots of people chattering to each other. When you use lateral inhibition in the lecture hall, it's like covering the mouth of the person next to you or shushing everybody so that the detail of that stimulus can be received more accurately. Does that make sense? Mm-hmm. Yep. Okay. We did that page, so we're on to tactile defensiveness. So we just wanted to provide a definition here. It's a subset of sensory defensiveness where a fight or flight reaction to touch occurs in response to stimulus that most other people would consider non-noxious. And again, this will be addressed more in the series on sensory modulation. So I'm not going to go through every detail on these pathways, but I, in my obsessive way, wrote it all down. So again, touch information is processed through three basic systems. One is the dorsal column medial lemniscal, or DCML, the anterolateral, which is also referred to as the spinothalamic, and then trigeminal thalamic. Remember, DCML is very much about discrimination, and some of the key points to know here that help to make this system better for detail is that there's precise representation, somatotopic representation. That means that the location of the actual nerve tracts are physically representative of where they are in the body, and that continues all the way up into the central nervous system with some minor changes around the thalamus. There are minimal number of relays, meaning there's very few synapses in the DCML from that tactile stimulus all the way up to the cortex, which means there's less opportunity or less need for that stimulus to be processed. There's very little convergence, and convergence, it was in our last lecture, we didn't talk about it a lot, but that's where a lot of information from a lot of different cells comes to one place. That doesn't happen in the DCML very much. Heavy reliance on lateral inhibition, which we already talked about, and again, think about the homunculus. So in terms of the tract, there's a stimulus in the periphery that is a single pathway to the cell body, which is in the dorsal horn, and then all the way up to the medulla where the first synapse occurs, and that's at a couple of different nuclei. Remember, nuclei usually mean that some kind of sensory integration is going to be happening. And then the next synapse is in the thalamus, then it goes up to the secondary and primary and secondary somatosensory cortices, and then from there to the parietal lobe. So the somatosensory cortices deal with the discrimination of that sensation. The homunculus lies in S1. S2 does a little bit more detailed discrimination and puts some information together. And then in the parietal lobe, there's a little bit of integration that occurs with other sensory systems. It's from there that all this information goes to the front of the brain where motor planning has to happen. So it's just something to keep in mind. All of this stuff has to be working well for us to be able to use our top-down kinds of functions. I think one thing that's interesting, I meant to say earlier, this neuro stuff is kind of fun facts to know and tell. I think one of the things that's interesting about the homunculus, yeah, I know,
For you.
is that it's flexible. We think too often about the brain being kind of this static thing, and we hit a lot on neuroplasticity in the last lecture. But I remember something that Tracy Stackhouse told us when we did a study group with her several years ago that really stuck with me, and it's about the homunculus being flexible. In constraint therapies, people have been able to do neuroimaging during a constraint process, and within 30 minutes of application of the constraint cast, you see new dendritic branching in the sensory cortex. I just think that's fascinating. This is part of why therapy can be so effective. Okay. One other point, the DCML does contribute somewhat to arousal modulation, and we'll talk about that a little bit more in the next slide. So anterolateral system, I'm just going to touch on briefly some key information. This will probably be addressed a little bit more in the modulation lecture. Remember, this is a system that's more responsible for that valuation processing that we talked about in the last lecture. It also has mechanoreceptors, and several different tracts that respond to pain, crude touch and temperature, and then also initiation of the chemical response to pain. There are several synapses that happen, some right within the spinal cord, so again, remember, less detailed information. This system is connected to the limbic system, in contrast to the DCML, which is basically not. So there's the other area that you get the emotional reactivity and also just regulatory things that happen. The other thing that's very interesting is that a very large percentage of the fibers of the AL synapse on reticular formation, which is part of why it can contribute so much to arousal regulation. There is some interaction of AL and DCML at the thalamus, and it's thought that DCML can inhibit AL transmission. Sorry about abbreviating, but and one of the examples used of that, of the DCML inhibiting AL transmission, is the effect that you can have on pain by use of deep pressure and proprioception. It can have an effect to diminish pain. Trigeminothalamic, there's the info for you and places to look for more if you're interested, but just it's basically the somatosensory system of the head and face. So again, why do we care about this information? What impact does processing interpretation and interpretation of somatosensory input have on function? I mean, that's really why we care. And the big word is praxis, and we're just going to touch on this briefly today because there is another cycle devoted just to praxis. That'll be cycle 6. But remember what this means. Praxis, the original term, means action based on will. Ayres talked about kind of 3 functions or 3 areas of praxis that are necessary for good function. There are other models that talk about more subcategories, but I still think in these terms: ideation, planning, and execution. And she suggested that dyspraxia is primarily a problem of organizing the planning for a motor act. And to be able to organize that planning, you have to have knowledge of objects and actions. Well, if you don't have a good tactile discrim system, you don't develop good knowledge of objects. If you look in the autism literature, the psychology talks a lot about object affordances, so having those ideas of what objects are for. That's based on sound tactile processing. And then praxis also requires motivation and intention. So if you have impairment in tactile discrim, you have limited body schema and percept, you have limited knowledge of objects and their actions, and you can have a limited knowledge of actions. That's probably more affected by proprioceptive perception, but the two work very closely together. Dyspraxia definition is the dyspraxias are developmentally based practic disorders with a variety of etiologies. And when the tactile system is involved, we talk about somatodyspraxia, which is an SI-based dyspraxia in which there's at least some evidence of a somatosensory impairment, so tactile and or proprioceptive impairment. But somatodyspraxia is also considered a more severe form of dyspraxia than the bilateral integration and coordination and sequencing praxis problems. And it's often associated with problems in other systems, such as impairments in vestibular discrimination and visual perception.
Robin did a great job going over all of the neurological foundations of the tactile system. And I'm going to talk a little bit about function, how we evaluate for tactile difficulties, and then how we write goals and address it in treatment. So Robin kind of already went over a lot of these pieces about functionally why is the tactile system so important. It is obviously connected to a lot of the other systems, so it's hard to just completely take out just the tactile system. We talked about body scheme, which involves the tactile system, but also proprioceptive and vestibular. Hand function, so how we manipulate objects within our hand, how we use tools, tactile and proprioception. The motor planning pieces, so somatodyspraxia, looking at the tactile and proprioceptive systems together. Activity level, so this can be from modulation pieces, so in response to touch, but also our kiddos that do a lot of seeking of touch, since they're not getting a lot of that feedback. And then also the emotional social development is really a big piece of the tactile system. So it's how we explore our world when we're born, infants, touching everything, putting everything in our mouth. That's another piece we'll talk about a little bit, is the tactile pieces of oral development. So how do we evaluate it for it? So right now, I don't think that we haven't all had a consistent way of that, how we're really evaluating for tactile perception. And so part of the goal of this lecture is to go through the standardized tests that we would like everybody to be using across locations when they're doing evaluations. So the MAP has a couple of really great standardized assessments, so finger identification, diagnosis, and the SIFT also has several good pieces, probably the most important ones to look at tactile perception, so finger identification, localization of tactile stimulus, manual form perception, and graphesthesia. And then we have some videos of this that we'll tell you in just a minute. And so we also talked a little bit about what are some non-standardized ways to evaluate for tactile perception. And that comes into play when you maybe have a child that can't participate in a standardized assessment. And so you might do some observation of motor planning, because oftentimes when there's tactile perception, you'll see the somatodyspraxia together. And so you might look at some of the motor planning pieces, body awareness, parent report, and then maybe tailoring some of the standardized tests that we had mentioned above. Robin also found online some non-standardized, standardized ways to look at stereognosis. So we are going to put that information together, and then we'll send that to you at a later date as well.
That's just talking about, how you learn to test stereognosis, for example, in school when you were testing a patient who had a stroke, for example. There's some standard sets of objects and some information about what normal range function is. So we'll put that together for you guys.
Yeah. And then at the end of this, there is at the end of this lecture, we'll talk a little bit about the evaluation template, but this is the actual dot phrase that you can add into your evaluation template to put in the tactile discrimination test into your evaluations.
So we're going to look at a few videos of the different tactile perception, tactile discrimination, and perception tests from the SIPT. We've just done some introductory items for each of the 4 tests. There's a little bit of description of process on the video, but there's not description of what the test is for. So the 4 tests are manual form perception. This is essentially a stereognosis test, and there is a section that gives you a visual representation of the object, and you identify the object that way. And then there's a section that relies on visual imagery, and you only get tactile input to identify the object. I'm going to go through all of them.
Yeah, go for it.
The other tests are finger identification. This is very similar to the finger identification on the map, just more items. And this measures perception and localization of tactile stimuli to the hand. Graphesthesia is a test in which the examiner draws shapes on the child's hand, and they have to reproduce it. And this gives you information about the discrimination of spatial and temporal qualities of tactile input. And then localization of tactile stimulus gives you perception and localization of tactile stimuli. This is the most specific tactile discrimination test. It's really about 2-point discrimination, essentially. It's a recording. So this is the manual form perception test.
So I'm going to put one of these blocks in your hand. You point to the picture here of the block in your hand. I'll put the first block in this hand. You point to the picture. Oh, she has some major attack. Now the block will be one of these. So that's good. And then you keep going. Should I pause it then? feel blocks at the same time. This hand will feel this block, and this hand will find one like it over here. Keep this hand here. Okay. Now this time we can look. Now this hand will feel this block, and this hand will find one like it over here. Good. Oh. Now, this block will feel this block, and this hand will find one like it over here. Now there is more. Begin here. Make sure to feel each block.
I'm cheating. Oh, it is the same. This feels like a rectangle. Oh, tricky. You turned it around.
Make sure to feel each block. So there's 5 items for right. Then after you've done all 5, you switch. And you say, now the other hand will feel, like this hand will feel this block, and this hand will find one like it over here. Make sure to feel each block. And then you do all that for 5.
So this is the finger identification test.
Touch that finger. Touch that one. Touch those. That time I touched 2 fingers at the same time, right?
Right.
That's that one. That time I touched 1 finger at 2 different spots.
Okay.
Now let's see if you can tell which finger I touched when you can't see which finger I touched. So that's that one. We can move on.
Okay.
I'm going to draw some designs
This
on the
is the
back of your
localization
hand
of tactile stimulus
with my
test.
finger. You draw the same thing
Oh, I'm sorry,
with
graphesthesia.
your finger. Draw what I drew. Draw it here. Draw it carefully. Now I'll draw something different on your other hand without you watching me. You draw the same thing. Draw it carefully. Oh, and then you record the directions. Yes, I'll tackle offensive issues.
I could see your hand that time.
Well, you can. Okay, so that's that one, and it's 14 items. For this one, we have to post.
And this will be the localization of tactile stimuli.
I'm going to touch you lightly with this pen. Put your finger here.
You're going to leave marks on me?
Put your finger exactly on the spot where I touch. Good. Now let's see how close you can put your finger when you can't see where I touch you. Hold it there so I can measure. Robin.
I told you I'm losing proprioception.
Yes. Okay. Go. Okay. Okay. Okay.
I didn't even get touched there. I just overshot. Name that neurological dysfunction.
Okay. Do you want me to do all of them?
No.
Okay. Finish that. Okay. Okay.
All right. So when the partners come to your site, they will review those standardized tests more in detail with everybody, and talk about what you guys have at your site and gather information about what still needs to be ordered. So this, the next couple slides are on intervention and how you treat tactile processing disorders. Tactile discrimination. Tactile perception.
I like that.
Tactile perception. Robin's gonna keep telling me that.
That's because Liz is telling me that.
Yes. So some activities, so covering equipment with some interesting textures. When you think about Airs and how she had her swings covered in carpet, there is definitely purpose behind that. So thinking about what other interesting textures you can cover using towels, other pieces of fabric, and then wash them right after you use them with every single patient. Towels are an easy one, or sheets and things like that we have around that you can obviously just toss in the linen area. Thinking of activities that cover the entire child's body, so crawling under pillows. Back in the day, we used to have ball pits. So thinking about other ways that the lycra swings, that you can have them crawl through the different textures. Tunnels that we have here that have different textures, so that covers their whole body, crawling through those textures. Encouraging the child to actively move through them, so that's another example of the tunnels. Looking at some activities where their vision is occluded, and so using things where you turn the lights down or maybe use flashlights just to make it a little more interesting, and then using like pillowcases where kids have to put their hands inside of that so they can't use their vision. Encouraging discrimination by finding those kinds of items. So I think we do I see a lot of this in treatment where people put puzzle pieces or little pieces of toys and popcorn, beans, things like that. So just to look at that tactile discrimination piece. Thinking about using other textures, shaving cream we use a lot, finger paint, lotion, using those kinds of things to write or draw on the skin and then wiping it off is a nice tactile activity. So even like drawing a picture of something with using shaving cream on their arm or their hand, maybe with their eyes open at first, then maybe with their eyes closed. Pretend shaving with their face, really thinking about their tactile, their oral, tactile, and their face. Applying face paint is a really fun one. So sometimes I've had like applying it to a child and then having the child apply it to you if you're really feeling very adventurous in your treatment, depending on what you're doing after that. Using different types of brushes on the skin to draw items, guessing what you're drawing with vision occluded, using equipment that combines that deep pressure and the tactile input, so rolling up really tight in a blanket, beanbag squishes, using the lycra swing, all of those kinds of things that provide some of that deep pressure and tactile together. Doing some activities that look at the localization of tactile input, so stickers, pieces of tape, things like that, putting them on the child's body, trying to see if they can figure out where they are without using their vision. Vibration is a really great tactile strategy. A lot of kiddos, I've seen such nice progress with tactile perception after using vibration. And I don't know if every site has this, but just a box of objects that have a lot of tactile different activities in them, so like pom-poms and whatever kinds of things that you guys, different brushes, feathers, things like that. So the goal identification, I'm going to run through some of this a little bit quickly so that we have some time for questions. When you're doing your goals, we really want you to look at what are the results of your standardized assessment to tell you that that child has difficulty with tactile perception, and your clinical observations, and then what are the functional deficits that are impacting that child from those areas of deficit. So oftentimes from a functional standpoint, you'll see goals in the following areas. So manipulation of fasteners, so buttons, tying zippers, things like that. Grasp on writing tools, so how they hold their pencil, how they hold their scissors, how they are using their hands together, so manipulation of tools. Finding objects with vision occluded, so thinking about function, so how do we all do this? So reaching into our pocket and figuring out what's in our pocket, using in our backpacks for kids at their desk. Oftentimes they're reaching in and trying to get something but not using their vision. Can they do those kinds of tasks? So how do you relate that to function? And then praxis-related goals that you often might see when you're looking at tactile perception or somatic dyspraxia, addressing play, self-care. So these are just some sample goals, and I was talking to Liz when I was putting some of these together because I was just kind of curious. I thought, well, I'll just look through some of staff's goals on there to see what's in there. And it turns out, as a group, we are not really that great at writing tactile perception goals. So I feel like it's an area of improvement that really we could focus on. So looking at what is the underlying deficit and then the desired functional outcome. So here you can see I've just put together a few different examples. So the patient will improve tactile perception for improved manipulation of fasteners, improve tactile perception to find objects with vision occluded, functional grasp on utensils, improve oral tactile perception to decrease overstuffing, drooling, being able to blow a whistle, drink from a straw, things like that. So, in conclusion, why is the tactile system so important? It is our first system online, like Robin was saying. It's the one that is first to develop in utero. It's how we start to explore our world. It contributes so much to social, emotional, physiological, motor, neurological development. It's really what drives us to explore the world. And impairments of this tactile perception is really a core deficit in many areas of occupational performance. So this is your homework, and Robin and I don't want people to get overwhelmed by it because it's it looks like a lot, but it's over the course of, the readings are obviously looking at those neuro pieces. I mean, Robin did a great job of explaining it. We both feel like you really need to take some time to read through the information to really absorb the neuro pieces of it. And then we want you to practice some of the assessment pieces, the MAP and the SIPT. And you can do that prior to us coming if you have all of the pieces there. If you have people at your location that are SIPT certified that are familiar with the test, you can start to do that together as a group. And then when we go out to visit you, we will also review some of that information as well. So when we come out to visit sites, we would love for you to choose a child on your caseload that you think has difficulties with tactile perception. And that's a child that we really want to be able to observe and to you to discuss with your partner. And we want you to be able to select one assessment that we could observe. It can be a standardized or non-standardized assessment of their tactile perception. And then one intervention at least in your session that you would do to address the tactile perception. And then talk to your partner. And these pieces are after the session. So we really want you to put those pieces of whatever your assessments are into what are the functional implications for this child and be able to talk through that with your partner. And then after we leave, we want you to be able to add the tactile assessment components of the evaluation template into your evaluations and be able to do the SIPT and the MAP pieces and be able to score them and add them into your assessment.
And just a note about assessment, we recognize that we have time limitations in assessment, and really the ultimate goal is that we're at least doing some standardized assessment of tactile perception, and we'd rather that you do one or two tests completely and have some standardization data than doing a bunch and not completing them. But it's also important to understand those non-standardized ways to look at these things.
I was also going to add, I know you were talking about as part of the follow-up, identifying a kid who you think might have tactile perception issues and doing this test on. A lot of questions that I've gotten from people are, well, I don't have any straight SI kids, or I don't know, if they have any SI issues, I don't think they do, or whatever. This could be done for any kid that you see. I mean, it could be a feeding kid, you can do tactile perception on them. So you don't have to think about it in terms of, are they straight SI or not? Because chances are they're going to have a comorbid diagnosis to their SI difficulty anyways.
Fine motor delay.
And including like fine motor delay. Probably good to test tactile perception.
So we have a few minutes for questions. If anybody has questions, please let us know. Turn your microphone on so we can hear you.
I have one regarding the finger localization or touch localization, like for the kiddos that touch and then kind of retouch. Like they have to touch somewhere and then they get where you've touched them. Count that? Don't count that? I'm not SIP certified, so I don't know how the complete standardization, but, and is that a tactile discrim issue for the kids that, it's like they almost need the feedback, like, oh, not there. Now it's.
Yeah, I think
Makes sense.
My understanding is you would score the final response, but you make note of that behavior that you've seen because it gives you more information.
Right. Okay.
Is that what you guys would
Because
do?
he could feel it, Oh, no, it's not here. It was here. No,
Mhm.
And I think
it's
you
the
can
right
correct
spot.
yourself, I don't think that's a problem.
No, I don't think so either.
My guess is it's in the manual.
Yeah.
Like, there's
Yeah,
no
we'd have to
strict
re-
guidelines in the manual.
We'd have to review the manual for specific scoring, but we think that you score the last one. And what we want to be able to do is make sure that there is somebody who's SIP certified or trained to go through some of those details of the tests with you guys, so, when we're on site, and then practice is the way to learn it. But we'll go through those kind of idiosyncrasies of administration and scoring with you.
And don't feel pressured to, prior to your partner coming, feel like you're supposed to learn this entire thing because, most people aren't SIP certified. This is a lot to bite off. So even if it's just you doing informal assessment during, the period up until the partner comes, then that's fine. And then it'll be reviewed with you more formally.
Ultimately, we want to make sure that people are engaging consistently in activities that will allow them to differentiate between a valuation system issue and a discrimination system issue. I mean, there's even some information on the SPM in the tactile section that is about tactile discrimination. It's very little. I wouldn't want you to base your final determination on that one item or two items, but we want you to be thinking along those lines. Go back to that chart that Zoe gave us at her conference that Liz has distributed and look at those issues. Is this a sensory perception issue? Is this a sensory evaluation or a sensory reactivity issue? That's how we want you to be thinking when you do assessment and treatment.
The other thing to note is I've made sure that at all sites there is scoring compatibility for these SIP tests. At the start we want people to test informally, but the long-term goal is that people can actually get a standardized result when they're testing tactile perception because you need to know norms and all that. So, that will also be reviewed with you as how to score. It's pretty easy when you have the SIP scoring bit.
Any other questions? Okay, so I think we'll sign off. Remember, take some time to read. I know it's not always easy to do, but it just makes the information that much richer. And we'll see you soon.
Thanks.
Thank you.
Thank you.
Let's see how many years.